Okay, so back from the fruits and the coffee, it's really a pleasure for me to introduce the first speaker, Dr. Richard Schwarz. He's a research scientist at Rice University, Houston, Texas, and I had the pleasure to work with him for 12 months, 13 months, back there in 2006. And Richard comes from a group that has long experience and has been really contributing for the area of optical diagnostics. They work from basic scientific understanding, all the light tissue interactions, is mainly for explaining how optical diagnostics can work for cancer detection. And this group has Professor Richard Scorton as the leader, and they have been working with instrumentation and also to translate all these optical technologies to clinical applications. So please, Richard, thank you very much for coming from Houston to share your experience on this research field.
Okay, good morning. First, I'd like to thank Dr. Bagnato and Dr. Karachi for the opportunity to speak with you today and for putting together this great conference and school. As Christina said, my name is Richard Schwarz. I am with the Department of Bioengineering at Rice University in the lab of Dr. Rebecca Richards-Cordum. And today I'm going to talk about optical diagnostic systems for precancer. And this work was done in collaboration with the University of Texas MD Anderson Cancer Center and the University of Texas School of Dentistry at Houston. So first, a brief outline. I'm going to start by talking about several different optical technologies that can be used for precancer diagnostics, including some of the basic terminology that we use to quantify diagnostic performance. And then I'm going to move on and talk about some of the translational clinical studies that we have going on where we're taking these technologies into the operating room or into the clinical environment and evaluating their performance. So in many epithelial tissues, such as, for example, the oral mucosa or the cervix, the development and progression of precancer and cancer change the optical properties of the epithelium and the stroma in ways that we can measure non-invasively. So in the epithelium, we have fluorophores such as NADH, FAD, keratin, and we can have metabolic alterations that change the concentration and distribution of those fluorophores in the epithelium. We can have thickening of the epithelium and changes in cellular morphology, nuclear to cytoplasmic ratio, and so on. In the supporting stroma, collagen is a major fluorophore, hemoglobin is a major absorber. We can have degradation of the collagen crosslinks, microvascularization, growth of new blood vessels, leading to changes in stromal autofluorescence and stromal absorption. And it's also possible that we can have stromal inflammation, which in some cases can be a source of false positive results for some optical techniques. One optical property that changes with the progression of disease is optical scattering. So you can see in this histopathology slide on the right side, a relatively normal epithelium. This is from floor of mouth. The epithelium is a few hundred microns thick. Below the basement membrane, you see the supporting stroma. And on the left side, you see cancerous tissue with higher nuclear to cytoplasmic ratio, pleomorphism, and a breakdown of the ordered layered structure that you see in the normal tissue. So as you can expect, the tissue on the left is going to scatter light much differently from the tissue on the right. If you measure the diffuse reflectance spectrum of a mucosal tissue such as the oral mucosa, you'll probably get something that looks about like this, with a strong absorption around 420 nanometers and then a double dip out here around 540 and 580 nanometers. The primary reason for the shape of this curve is the absorption spectrum of hemoglobin, shown here in the inset, oxygenated and deoxygenated hemoglobin, with a strong absorption right here corresponding to this dip. And so the changes in hemoglobin absorption can affect not only reflectance spectra, but also fluorescent spectra, either due to absorption of the excitation light or absorption of the emitted light after fluorescence occurs. And finally, changes in autofluorescence can occur in the tissue, represented here by these characteristic absorption and fluorescence spectra of NADH and FAD shown at the top. And we can represent these either in the two-dimensional plots shown here or through the use of an excitation emission matrix shown along the bottom here, with the excitation wavelength along the vertical axis, the emission wavelength on the horizontal axis, such that if you excite NADH at 360 nanometers, for example, the cross-section of this graph along that horizontal line would represent the fluorescence emission spectrum. So I'm going to talk about three particular optical diagnostic modalities today. They are macroscopic or wide-field autofluorescence imaging, depth-sensitive optical spectroscopy, and high-resolution imaging. Now, these are just three of many different optical techniques that can be used to interrogate tissue in vivo. And you'll hear about probably many others, optical coherence tomography and different things from other speakers. The reason that I'm going to talk about these three in particular is that we have found it very useful to use these in combination with each other in the clinic and in the operating room. The reason is that they provide complementary diagnostic information over different spatial scales, going from a large spatial scale of several centimeters for wide field imaging down to the sub-millimeter level for high resolution imaging. And these are relatively easy to implement in the clinical setting and relatively rapid diagnostic methods that can be used in a multimodal combination. I want to talk a little bit about design considerations for translational clinical studies. Now, keep in mind that I'm not talking about instrumentation that's going to be for treatment or that is going to be the primary focus of what's going on in the operating room. In this case, I'm talking about diagnostic instruments that are intended to assist and support the clinician in evaluating particular tissue sites, either before or during surgery or in the clinic prior to surgery, for example. So, and also keep in mind that these instruments are typically used on many different protocols at many different clinical sites for quite a few different purposes, often multiple times in the same day, and so we end up having to carry these things all over the place, all over the medical center in Houston to different clinical locations, and so they have to be compact and portable, but they also have to have a high degree of modularity and flexibility so that we can mix and match different modalities. We can say for this patient we want to do this type of measurement, for this patient it's more appropriate to do this. If the clinician wants to try a different excitation wavelength, we can easily switch things out. But in any particular configuration, you have to have a system that is stable and reliable enough that you can get good, consistent data that will be meaningful over a long time course, because in many cases we're following patients for a long period of time. So they have to be pretty stable over time. And finally, these instruments need to be fast. We are, as I said, these are diagnostic instruments that are in support of the clinician's evaluation of the tissue. And so it's important for us to be able to get into the operating room, set up, do our measurements, get the information to the clinician that the clinician needs, and then get out of the way as fast as possible so that whatever needs to happen can happen. And we've gotten better and better at this over time to the point where now we can usually, the time from when we enter the room, set up all of our equipment, do the measurements, and get out of the room, we can usually get that down to about 5 or 6 minutes now for doing 3 different modalities. So we're getting better at that than we used to be. So I'll talk a little bit about some of the about these three modalities in particular. So first, macroscopic autofluorescence imaging. This is the system that we use in the clinic currently. It's a compact and portable version. It does white light imaging and 405 excitation fluorescence imaging, which you see along the bottom here. Field of view of about 4 to 5 centimeters. And it provides a live video display that the clinician can look at during the course of the imaging. And you can see here what normal and abnormal tissue look like under white light and then under autofluorescence imaging. Again, this is without any contrast agent. This is just the natural tissue autofluorescence. So here on the right lateral tongue, you see a moderately differentiated cancer with a characteristic loss of blue-green autofluorescence and a little bit of the reddish porphyrin fluorescence at the center of that lesion. The portable system that you just saw was preceded by a larger system that you see here based on a commercial dental microscope. This is one of the things that we typically do. We will build a large system that does many different measurements and measures quite a few different parameters, and use that system in a study to kind of explore the parameter space and see what particular features are most diagnostically useful. And then once we have identified those that are most diagnostically useful, we'll build the smaller portable instrument that just does those measurements. So here you see measurements under different conditions: orthogonal polarization, fluorescence, different narrowband excitation, showing different sensitivities to depth. You see blood vessels at different depths here, and so on. One thing that you can do with these autofluorescence imaging modalities is to generate probability maps of disease based on the autofluorescence image, and then overlay those maps back onto the white light image. And so this shows an example in which a probability map has been overlaid onto a white light image of the tissue, and you can see the correspondence with histopathology here. If we go from A to B, we're going from an area of carcinoma in situ to mild dysplasia. If we go from E to F, we're going from an area of normal to carcinoma in situ. So you can see a general correspondence here to what we see in the histopathology. So this wide field autofluorescence imaging is very useful for rapidly scanning a large region of tissue, and then we can go in with a point probe, either a spectroscopic probe or an imaging probe, and examine particular sites in more detail. So this is the instrument that we're currently using for depth-sensitive optical spectroscopy. It is again a portable device that uses 385 nanometer excitation and also does reflectance under white light illumination. It has a depth-sensitive probe configuration that's configured to target the basal epithelium and shallow stroma where the early precancerous changes occur. And it takes about 5 seconds to do a measurement, and then it produces an immediate posterior probability of disease, a percentage probability based on the optical measurement, and a prediction of whether the site is normal or abnormal. And there's nothing like a real-time prediction to tell you whether you have an instrument that's working well or not. And here you see the spectra. These are average spectra from a study of 124 subjects, showing normal, mild dysplasia, moderate to severe dysplasia, and cancer spectra for a particular excitation wavelength. This is a detail of the fiber optic probe that's used in that system. It has several different excitation channels, including some that target shallow epithelium, the basal epithelium, and deeper into the stroma. It has a ball lens coupled design, and basically you see the depth response of the probe. We have a shallow, a medium, and a deep channel response depending on which excitation we're using. Once again, the small compact instrument that you saw was preceded by a larger instrument that measured many, many different excitation wavelengths and parameters, and that was the instrument shown here, which I'm sure Christina remembers well. So one advantage of doing the spectral measurements is that you can represent the data in the form of an excitation emission matrix, which you see here. This is an average EEM for that study that I just mentioned. It looks a little bit choppy due to the discrete excitation wavelengths and the filtering setup that we're using, but you get the general idea. There is a strong contribution from tryptophan down here, NADH, and then FAD, and the contributions of collagen all throughout here. And you can see some of the correspondences between the fluorescence image and the spectrum. So here's an image that shows a lot of red fluorescence, and when you look at the spectrum, sure enough, you see a big red peak out here at 635 nanometers from the porphyrin, and then you see a very low blue-green fluorescence in this region here. Another advantage of doing spectral measurements is that we can compare with Monte Carlo models of light propagation in tissue. So this diagram shows an example of one particular model that we've used, with the epithelium broken up into superficial, intermediate, and basal regions, the stroma broken up into a superficial and deeper regions. And so each of these, in the model, each of these regions has been assigned particular optical properties, absorption and scattering properties, and particular fluorescence properties with a characteristic fluorophore assigned to that region. And the graphs here show comparisons between the clinical data, shown as the solid and dotted lines, versus the simulations, which are shown as the square and circle marks that you see there, showing that we're in rough agreement with the clinical data. The third modality that I'm going to discuss is high-resolution imaging. This is another fiber optic probe-based technique, and in this case, we're using 455 nanometer excitation. The field of view of this probe is 720 microns, or depending on the probe the particular probe bundle that you use, you can have different sizes. And the resolution, transverse resolution, is about 4 microns. And we use this in combination with a topically applied contrast agent called proflavin. Proflavin is a fluorescent dye that highlights nuclei, and so the nuclei appear bright in the image. And so this is an example, and again, we have a live video display that the clinician can see as we're moving the probe around on the tissue site. And so here, this is a cancer patient measured in the operating room. The probe here is placed behind the lesion. This is a normal site, and this is basically what normal oral tissue looks like, viewed with the high-resolution imaging probe. Those bright dots are nuclei. If you look closely, you can see the outlines of cells there in the superficial epithelium. And then if we move the probe forward onto the lesion, this is a moderately differentiated cancer, we see this very crowded, disordered, high nuclear to cytoplasmic ratio image that's characteristic of cancer viewed with this imaging device. This is a diagram of the system itself. It is basically a fiber optic bundle-based epifluorescence microscope. We have an LED for illumination, which is the case with many of our compact portable devices. The light is coupled by an objective into the fiber bundle and then imaged back onto a CCD. And this is a picture of a resolution target, and if you look at the magnified center of that image, you'll see that the image is made up of these little small circular pixels that are actually the individual 2-micron fibers in that fiber bundle. One of the nice things about this system is that you can use it to map out lesions in real time in the operating room. So this is that same patient with the probe placed right on the border of that lesion, and you see the characteristic crowded nuclei, abnormal looking appearance. And then just by moving that probe one probe diameter over, less than a millimeter, you see this. So we're really going right across the border of that lesion. You can use that to map out what we're seeing in real time for the clinician. All of these optical techniques that I've described, the spectroscopic and the imaging techniques, are all compatible with the use of various types of optical contrast agents. And those are, you can think of them as in some way analogous to the stains that are used in histopathology, but in this case we're using them for either in vivo or ex vivo use on resected specimens. And typically these contrast agents include a targeting element, something that's going to bind to whatever your target you're interested in, and an optical reporter, that is a fluorescent dye or some sort of nanoparticle or something that you're going to be able to measure with your optical system. And so we have quite a bit going on with, you can look at some of the posters in the poster sessions with work with NBDG, which is a fluorescent glucose analog, the EGF peptide, various antibodies and nanoparticles and so on. In this particular talk, the contrast agent that I'm really going to discuss is proflavin. That's the one that we're using in the in vivo studies in combination with the high resolution imaging. Now, if you're going to evaluate diagnostic performance, Dr. Magnato talked about looking at the fundamentals and the foundations, so I'd like to talk about that a little bit here. You have to have some sort of gold standard to measure by. And so typically, the gold standard is going to be histopathology, so microscopic examination of a tissue sample that's been taken from the patient, and which is typically used as the standard for diagnosis. So here you see an example of the different grades of dysplasia shown, mild, moderate, and severe dysplasia, and perhaps carcinoma in situ, and then finally cancer. But there are a few things to keep in mind when you're using gold standards. One is that grading of dysplasia is subject to intra-examiner and inter-examiner variability. And just as an example, there's a study from 1995 where they asked a number of pathologists to go reread pathology slides that had been received some previous read and diagnosis, and they looked at at how well the new reads correlated. And then they had those same pathologists read those same slides 6 months or a year later, and they looked into the correlations there. And what they found was that exact agreement, that is within the exact same category, was about 51%. Within one histologic grade, it's quite good, up to 92%. But this one histologic grade can make a big difference if you're talking about mild versus moderate dysplasia, or mild dysplasia versus no dysplasia at all. And so these things can kind of play havoc with your ability to properly evaluate the diagnostic performance of your instrument. Another thing to keep in mind is that for normal sites or sites in healthy volunteers, you probably are not going to have a histopathology, just because you're probably not going to have biopsies taken from those normal sites. And finally, site correlation is absolutely essential. You have to be very, very certain that your gold standard came from exactly the same location where you did your measurement. And I want to talk about that a little bit more. Let's suppose that you have a surgery taking place and you're going to end up with a surgical specimen that is a fairly large specimen that includes a lesion. And that specimen is going to receive a histopathology diagnosis that is probably going to correspond to the worst thing that they found in that piece of tissue. But let's suppose that you have a few biopsies that were taken within the specimen at particular measurement sites, and you might have say, for example, these 3 biopsies here, and there is no reason why those biopsies would necessarily have the same histopathology diagnosis as each other or as the overall specimen. And then let's say further that you looked at the individual regions within a biopsy, say going from anterior to posterior or something along the biopsy slide cross-section there. You may get several different histopathology diagnoses at each of those points. So you have to think very carefully about what makes sense to use as a gold standard, because if you haven't thought it through carefully, you're going to end up kind of choosing whatever you feel makes sense given the various options that you have, and it can really impact what your diagnostic performance turns out to be. So one thing that might make sense is to correlate some sort of macroscopic measurement to a histopathology diagnosis at the specimen level, perhaps a large probe measurement to something at the biopsy level, and a small probe measurement to something within a biopsy. But it's something that has to really get a lot of attention in order to do it right. Now, once you have your gold standard, are going to typically evaluate performance. One of the common ways to do it is through calculations of sensitivity and specificity. And so this is pretty basic here, I'm sure, for most of you, but you can use a 2x2 table here where you say the rows represent whether the disease is present or absent due to, according to the gold standard, and then whether your test was positive or negative. And so you have your true positives that tested positive and disease is really present, true negatives where it tested negative and disease is absent, and then you have your false positives and your false negatives. And the sensitivity defined here is basically your ability to correctly identify disease when it is present, and your specificity is your ability to avoid calling normal things disease. Now, if you're measuring a single parameter and calculating, evaluating your diagnostic performance based on that parameter, you might vary your threshold value that you use in your test if it's a quantitative parameter. And as you vary that threshold value, the sensitivity and specificity will change. You can increase your sensitivity at the expense of specificity or vice versa. So as you move the threshold through the distribution, you will go from a high sensitivity, low specificity down to a low sensitivity, high specificity, and basically you want to get this curve called a receiver operating characteristic curve, or ROC curve, as close to this point here as you can. And so if you have a perfect test, the area under that curve is 1. This is sensitivity plotted against 1 minus specificity. So area under the curve is 1 for a perfect test. If you have a useless test that is equivalent to a coin flip or some equivalent randomly generated procedure, then your area under the curve will be 0.5. It will lie along this line of chance here. Now, having just discussed sensitivity and specificity, I will say that sensitivity and specificity values alone are pretty meaningless unless you know something about how the clinical study was performed and how the data were evaluated. The literature is full of all kinds of pilot studies in 5 or 10 or 12 patients that show 100% sensitivity and specificity, and they simply do not hold up whenever those procedures are taken out into a more demanding and more realistic clinical environment. And there are several reasons for this. One is pretty obvious. You need to make sure that the analysis procedures are independent of the gold standard, that you didn't analyze the abnormal sites differently from the normal sites. So that's pretty obvious. But some other things are a little less obvious and need to be considered carefully. One is, what are the procedures for data collection, quality control, selection of images and data that are included in the data set, and the selection of regions of interest in the images, and whether those procedures are blinded to, for example, the gold standard, or blinded to even to clinical impression can make a big difference in your data set. In many cases, the outcome of a particular clinical study may depend as much on what data was selected to be included in the analysis as much as it does on the analysis of the actual data that was finally included. And finally, our training and validation sets to use to minimize the risk of overtraining, and I'll talk about that a little bit further here. Let's suppose that you have 2 parameters that you've measured, and you plot those 2 parameters against each other, and you have some normal sites shown in blue, some abnormal and shown in red, and you say, well, it looks like most of the red ones are up here, most of the blue ones are down here, so I'm proposing to draw some sort of threshold line here to separate them. And that looks like a pretty good first shot at it. Well, you can certainly do something like this, and you can report that you got 100% sensitivity and specificity. Obviously, that's not going to hold up once you take a larger data set. At least I imagine that it probably wouldn't. And it looks pretty obvious when you look at it this way, but there are many, many cases where people apply quite powerful mathematical techniques to small sets of data and basically do this and report results that are not going to hold up in the long run. So one thing that you can do is you can use a training and a validation set, or a training and a test set. So in the training set, you explore your data, you select your parameters, you develop your algorithms, and you treat the sensitivity and specificity and diagnostic performance in the training set with caution. And then whatever algorithms you have here, you hold those out, and you have a separate validation set of data that was held out of the training set, collected either concurrently but not yet analyzed, or collected separately, and you apply your algorithm to the validation set, and that's where you report the performance, and you see how well you did. If you have any doubt about the importance of this issue of overtraining, it's pretty easy to prove it to yourself. You can do this by just generating some random data and trying some algorithms on it. So for example, here I'm going to show you data that was generated randomly in which the distributions of 10 parameters were generated from exactly the same normal distribution for normal and abnormal sites. So there is no difference between the normal and abnormal probability distributions here. So the area under the curve should be 0.5. This is the training set. This is the number of parameters selected by the algorithm. And this is the validation set down here. And so you can see that if you just look at a training set, you say, yeah, I'm doing really well. I'm up here with 0.8, 0.85, area under the curve. It's all artificial. As soon as you apply that algorithm to the validation set, you find what it really is. It's a pretty useless test, as it should be, because those distributions for normal and abnormal are identical. That we just saw was for the case of 20 subjects in that, in that simulation. If you get up to 500 subjects or so, it looks better. The training set isn't quite so artificially elevated. So if you have a sufficiently large number of subjects, then you can, to some extent, do better with the training set. Just to show the other case, this is the case where I've generated a training set and a validation set, again, randomly, but there is a difference between the data generated randomly for normal and abnormal sites. They're shifted by a standard deviation or so, so there should be a huge difference here between normal and abnormal. And so sure enough, in the training set, you see very high performance, and then in the test set, it is actually good performance as well, not quite as high as in training, but it does give you the good feeling that you're doing something well. And by the time you get up to 500 subjects, you're tracking pretty well between training and tests. So it's very important to keep this in mind, and also to keep in mind that if you just collect a single set of data and you analyze it and you report the results, basically you are using a training set. So now I'm going to go on and talk about some translational clinical studies that we have done or have in progress. This is a study of spectroscopy in 124 subjects, and this is the point probe spectroscopy device that I showed earlier. And these are average spectra collected throughout the study. In the top row, you see fluorescence measurements, and in the bottom, reflectance measurements. These are from the probe channel that targets the shallow epithelium. These are from the probe channel that probes deeper into the stroma. And so one thing you can see is the difference between the different diagnostic categories. These are from histopathology, normal, mild dysplasia, moderate to severe dysplasia, and cancer. And you can also see differences between the shallow and deeper measurements. Here, you're seeing a notch in the fluorescent spectrum, which is partly due to the absorption of hemoglobin in that 420 nanometer region. And so in doing these studies, this is the receiver operating characteristic curve for the training set on the left and the validation set on the right. Again, the performance was a little bit higher in the training set, as you would expect, but the validation set still has an area under the curve above 0.93, and so we're quite happy with the performance of spectroscopy in that data set. This is an interesting study of multimodal imaging. We used macroscopic wide-field imaging in combination with high-resolution imaging in a study of 100 oral sites in 30 patients. And this is one of the first patients that we measured using this combination. It was very interesting. when we did this measurement. This patient had come in with a biopsy from a previous, from a different institution that indicated dysplasia. So the patient came in and was scheduled to have an ablative procedure. So at the time of the surgery, we were in the OR prior to surgery, and the surgeon was looking at the region here, basically said that at that particular time there wasn't really much to see just with the unaided eye. There wasn't really anything clinically visible in that region. The wide field fluorescence imaging showed a distinct dark patch right here, which hopefully you can see with the room light here. So there was this very pronounced dark patch on the ventral tongue that kind of grabbed everyone's attention. And so the surgeon went in with the high-resolution imaging probe and kind of explored that region and found that in the area designated 1 here, that the nuclei looked fairly well-spaced and fairly normal. And then that was true throughout much of this dark patch, but over here in the region marked 2, that there was right along this center line, there was a region where the nuclei looked crowded and looked like it had a high nuclear to cytoplasmic ratio. And so 4 total biopsies were taken. There was the 2 at the site shown here, there was another about right there, and then another on this side. The only one that showed moderate dysplasia was this number 2 here that had been identified using the high-resolution imaging probe. The others all showed either normal or mild dysplasia. And so this was a case where that site would not have been biopsied, would not have been found without this combination of imaging techniques. So in that study of 100 sites and 30 patients, we plotted the data using a parameter from the wide field imaging along the horizontal axis, shown here, the normalized red to green autofluorescence ratio, and a parameter from the high resolution imaging, the nuclear to cytoplasmic area ratio from the image along the vertical axis. And when we did that combination plot, we found that most of the normal sites fell on this side of this line here, and most of the abnormal sites on that side. But it's interesting to look at these. We were 98% correct with the normals, 95% correct with the moderate dysplasias to cancers. But look at these mild dysplasias. The mild dysplasias are the triangles. About half of them are on this side, and about half of them are on that side. And this brings up something that we see over and over again with mild dysplasia in the oral cavity. We never know where to put it, whether to put it with the normals or the abnormals, which corresponds to the clinical situation. It's something where there is not a definite standard of care associated with a diagnosis of mild dysplasia. Typically, these patients are followed over a long period of time, followed very carefully. Biopsies are done as needed, and they wait to see if something develops. So what we find is that when we measure mild dysplasias in the oral cavity, they seem to fall into 2 groups, some that appear to be normal looking according to optical techniques, and some that appear to be abnormal looking. So we've tried to follow this up to some extent by doing some initial immunohistochemistry on the tissue samples from this particular study. So we looked at the markers Ki67, P63, and PHH3. These are markers that have been either associated with or investigated for association with high-grade dysplasia or progression. And so we found that if you look at the optics negative mild dysplasias, those are the ones that look relatively normal by our methods, versus the optics positive mild dysplasias, those are the ones that appear abnormal by our optical methods, that you do see some differences in the immunohistochemistry. And so in this particular study, we tried to stratify the mild dysplasias by P63 status, and we found that most of the ones that fell on the abnormal side were P63 positive. Most of the ones that fell on the normal side were P63 negative. So it's very interesting to us, but I will caution you that this is a very small number of sites. It's a very preliminary result, and we're intending to follow this up with going back and doing IHC on a larger set of samples up to several hundred samples that we have from different types of studies where we've seen the same pattern with mild dysplasia kind of falling into two different groups. So I've talked a lot about the oral cavity, but there are other sites that we measure as well. Here are some images taken with the high-resolution device of the oropharynx and the larynx. Here's the posterior pharyngeal wall, benign and malignant tonsillar tissue, benign and malignant larynx. These images are courtesy of our collaborators at Mount Sinai School of Medicine. These are some images of esophageal tissue. This is benign squamous mucosa, benign gastric mucosa, Barrett's esophagus, and esophageal adenocarcinoma. And again, these images are courtesy of collaborators at Mount Sinai. And so we have participated in an esophageal screening study in collaboration with Mount Sinai School of Medicine and the Cancer Institute at the Chinese Academy of Medical Sciences. So SciCams, this group, has a screening team based in Beijing, China, that goes out to different provinces around China and sets up esophageal screening at regional hospitals. And so we and the Mount Sinai team went along with this screening group, and we performed high-resolution imaging in combination with the endoscopy that they were doing as part of their esophageal screening procedure. So this shows the hospital where the screening was taking place. The high-resolution probe basically goes down the working channel of an endoscope, so it just goes right in down that channel. Here you see the high-resolution probe emerging from the endoscope here inside the esophagus. And this is basically what you get. You get something that is similar to, analogous to what you see in the oral cavity, with normal nuclei here and a cancerous site shown here. Just looking quickly at diagnostic performance in that study, this study has taken place over the course of a couple of years, a couple of different sites in China. So the data were divided into a training and test set, and then a recent set of data that were taken in Feichang and Dongping were assigned to a validation set. And so you can see that the diagnostic performance, and again, this is based on automated calculations of parameters calculated from the high-resolution image compared to histopathology. So you can see that the area under the curve is above 0.9 for all of those cases. We also do measurements of cervical tissue in vivo. So this is a study of 143 cervical sites in 86 patients. The study was carried out in Botswana. And so here you see a normal site imaged using the high-resolution imager and was confirmed to be normal by histopathology. Here is an abnormal, a clinically abnormal appearing site on the cervix, imaged using the high-resolution device, and was found to be CIN3, cervical intraepithelial neoplasia 3, a high-grade neoplasia. And in looking at within the training set, this shows a bar graph of the nuclear to cytoplasmic ratio that was calculated for normal and benign tissue, low-grade dysplasia, and high-grade dysplasia. And you can see that the nuclear to cytoplasmic ratio is much higher in the case of high-grade dysplasia. This is an interesting case where it was a clinically abnormal appearing site. However, the high-resolution image showed somewhat faint but fairly well-spaced and fairly normal-looking nuclei. This turned out to be a false positive according to clinical impression. The histopathology was HPV effect, which is non-neoplastic, and agreed with the high-resolution imager. Diagnostic performance is shown for the training set here. This ROC curve corresponds to the automated algorithm diagnostic performance calculated based on the nuclear to cytoplasmic ratio. This is the performance of clinical impression in that same data set. And these two dots here are the performance of to observers subjectively interpreting the high-resolution images, looking at the high-resolution images and stating whether they believe that that showed a normal or abnormal site. So there are different ways that you can arrive at diagnostic results and then calculate and report those values. And these are the values in the training set and in the validation set of 60 patients. Now, I've talked about evaluating the diagnostic performance of these different types of devices, but I don't personally really see these devices as diagnostic tests. The way I see them is that they are tools, very useful tools that can be used by a knowledgeable clinician to help see things that are otherwise not evident. And so there are several different clinical situations where tools like this can be useful. So one is, as I've already described, pre-surgery, during surgery, and post-surgery. So here's another example. This was a 79-year-old male patient measured in the clinic on a clinical visit about a month prior to surgery, which I'm calling day 1 here, just to give us a starting point. And at that time, the patient's left lateral tongue was normal, appeared normal in the autofluorescence image, appeared normal according to the spectrum, and the right lateral tongue showed this lesion here, which was considered high risk clinically. You see the very distinct loss of autofluorescence and a very low blue-green autofluorescence in the spectrum. This is that same day 1 image here. This is on day 37, immediately prior to surgery. You can still see that dark region here. This is immediately before they took this area out. And then this is day 203. This is much later, many months later. You can see the post-surgical scar in the autofluorescence image. If you can see that in the display there. And at the time of surgery, these were some images collected by the high-resolution device at this region out here, away from the lesion, showing normal mucosa, and then right here in the center of lesion, showing the characteristic abnormal appearance. And these are the histopathology results that went with those sites. So that's during surgery. Now, another situation where these tools can be really useful is in surveillance of patients who are at high risk. So this is a very interesting case of a patient that we've been following for going on a couple of years now. A female patient, a non-smoker, age 55. I'm calling this day 1. This was on the first clinic visit where we did optical measurements. So on the left lateral tongue, that's the normal side. On the right lateral tongue, there was a clinically abnormal low-risk site. You can see a very, very, very faint loss of fluorescence in that autofluorescence image there. The spectrum looks pretty normal. That was on day 1. We measured this patient over the course of about 7 or 8 clinical visits over almost a year now. We go up to day 611 here. And it's quite remarkable to see what happened here. So we went from, you can see all the different clinical impressions each time the patient came in: leukoplakia, irritation, usually abnormal low risk, all the way up to day 611 when it was considered abnormal high risk. And if you can see these autofluorescence images, they basically show that region progressively becoming larger and darker. The loss of autofluorescence becomes more pronounced over that couple of years. And this is where I said it's very important to have systems that are stable enough to do long-term measurements that are meaningful over an extended period of time. If you look at the fluorescent spectra, they start out pretty normal up through day 196. Then we have a low-looking one here, pops back up a little bit and then down again. You can certainly see that there's some sort of transformation going on in here. But then if you look at the histopathology, biopsies were taken on 3 occasions: mild dysplasia here, mild dysplasia here, and then finally on day 611, we got a moderate dysplasia. So you can it's kind of a remarkable situation where you're really seeing the progression of this particular lesion over a long period of time. and you're seeing changes that can be measured optically, perhaps even before they show up in the histopathology result. Now, another situation where you might consider using optical techniques is in not just surveillance of high-risk patients, but say, well, can we extend this to some sort of more general screening? That gets a little more difficult because if you're screening a general population, first you have to have a really high specificity in order to be effective. And second, if you're looking at a more general population, there is a wide variety of benign lesions that affect, for example, the oral cavity that can cause all sorts of problems with your optical diagnostics. So what we're trying to do is to make a catalog of different types of benign lesions and see how they appear by our different optical methods. So for example, here's a fibroma. This is what it looks like in the autofluorescence image. This is a high-resolution image. Nuclei look pretty normal. This is a Pymphagoid lesion. You see a pronounced loss of autofluorescence in the autofluorescence image there. This would be considered a false positive. This is a non-dysplastic lesion. But we think that we may be able to save rescue lesions like this from the false positive category through the use of high-resolution imaging in combination. So the high-resolution image looks pretty normal, which is nice. Here is a lichen planus that shows a distinct loss of autofluorescence here. In the high-resolution image, however, we have nicely spaced, pretty normal-looking nuclei. So we are in the midst of a fairly large study in collaboration with the University of Texas School of Dentistry to look at a variety of patients with these different types of benign lesions and try to kind of get a better handle on what they all look like using the different optical methods. Now, we still do run into trouble such as this one here. This is a lesion that was, this is a leukoplakia that was mild dysplasia according to histopathology. Doesn't show much loss of autofluorescence, but when we look at the high-resolution image, all we see is a lot of keratin. That's keratin right there. We don't see any nuclei. We're not quite sure how to evaluate this. So these are things that we're working on, trying to figure out whether there is information in the keratin patterns that we see, and so on. So that is to be continued. Now, I'll just end with a mention that we are taking some of these devices out to health fairs and community screening settings. Here's an example from just last month. We took some optical devices to a health medical camp screening in East Texas in a rural community where they were providing medical services for a lot of uninsured people who would probably otherwise not have access to these services. And so we went along and did some of our measurements as part of the oral cancer screening. And these are images from one particular patient who was screened who was identified by the clinician as having a lesion that was quite suspicious that needed to have some attention, that the patient needed to come in for a biopsy and further evaluation. And it was interesting to be there and see how this played out, that first of all, the clinician's clinical diagnosis, was based on a number of factors, not just the autofluorescence imaging, but also things like the patient's self-reported history and the location of the lesion and so on. But the autofluorescence imaging certainly did show a small region here that was of concern, and that was part of the reason for the diagnosis. But one thing that was very interesting was that the fact that we were able to take these images and show that the clinician was then able to point to these images and show the patient what he was concerned about, that was the factor that actually convinced the patient to come in. So it was interesting to see that the imaging instrument had not only a role in the diagnosis, but also in the clinician to patient interaction. And I think it made the difference in getting this patient to actually contact the School of Dentistry and get scheduled to have a biopsy and to get evaluated. So in summary, these non-invasive optical modalities can be useful in detecting precancer and cancer in vivo. They are often best used in combination, where they can different types of modalities have different strengths and different weaknesses, and they can complement each other. And they can be used in different settings, including the preoperative, intraoperative, and postoperative settings, in surveillance of high-risk patients, and in the hands of an experienced and knowledgeable clinician, they can also support screening in a more low prevalence community setting. So that is all I have for today, and I'd be happy to take any of your questions. I'd just like first to acknowledge these members, current and past members of the Rice Lab, our collaborators at MD Anderson, the University of Texas School of Dentistry, and Mount Sinai, and funding from the National Institutes of Health and the Cancer Prevention and Research Institute of Texas. And thank you, and I'll be happy to take your questions.
So my question is, how do you deal with patient movement, and particularly with your depth-sensitive spectroscopy, where you've got a 5-second measurement time? If the patient moves, is that then probing a separate area, and how do you map that to the larger area of interest?
Yes. Thank you. That's an excellent question. So there are several parts to the answer. The question is about patient movement. If the patient is moving during the measurement, what effect does that have? So it's certainly something that we worry about all the time. In the case of imaging measurements, the best thing that we can do is have a very short collection time, short exposure, and to take a lot of images in rapid succession. And it's sort of like taking pictures of the family. You take a lot of pictures, and you hope one of them in there is going to look pretty good. But certainly the short exposure, the shorter the exposure, the better. We find that if you're under 100 milliseconds exposure, you can do pretty well. If you get over 100 milliseconds, you start to see a lot of blurring due to patient movement. In terms of the spectroscopy, one advantage that we have is that in many cases, the measurements are being done immediately prior to surgery with the patient under anesthesia. So in that case, the patient is at least not moving voluntarily. There may be movement due to breathing and so on, but that does reduce the patient movement quite a bit. But for probe measurements with the patient awake, which we do frequently, it can be quite challenging. And one thing that we do is for spectroscopy, for example, we always do 2 successive measurements in the same. The clinician places the probe, and we do 2 measurements instead of 1, and we evaluate right in real time right there. You can see whether there was movement or not, depending on whether those 2 measurements look basically identical or whether one looks a lot different from the other. And so we'll ask the clinician to, you move, please, please do the measurement again. And it all comes back to the same thing I was discussing earlier regarding the correct registration of the measurement site with, to make sure you really know exactly where you were when you did that measurement. Also complicated by the fact that some of these have to be done with the lights off, so it's hard for the clinician to sometimes see where the probe is placed. It's a great question. Thank you. Yes?
When you do the fluorescence measurement, we see the spectrum coming up and down, and we see modification on the spectrum itself. Now, coming up and down could well be coupling less excitation light to the tissue. But that seems to be complete out of your... Do you take that in account? I mean, how much light is being coupled to the tissue?
Yes, all of the spectra that you see are corrected for their energy corrected for the amount of energy delivered to the tissue. So this is something that we measure in our standards measurements on a regular basis, and it's corrected for in the spectrum. You're also seeing spectra that have been there. I'm only showing the spectra from particular excitations that we've found to be most diagnostically useful and that are easy to show what they mean. We collect many different spectra that are a little more difficult to interpret. That particular one, I'm showing the blue-green fluorescence emission at about 380 nanometer excitation, so it's pretty easy for that one to kind of see what's happening in terms of the absolute intensity.
Thank you for your talk. It's an impressive technology. As far as I understand, you used this technology only on detecting the cancer on the surface of the tissue, but I know that not all the cancer can be on the surface.
Yes.
Is it possible that we apply this technology in if the cancer is inside the body or organ?
Yes, thank you. Yes, the question is about the depth of the lesion and how deep we can measure relative to different superficial or deeper cancers. So the methods that I've described here are we're generally looking at pretty superficial tissue regions. So the high resolution imaging is very superficial, just looking at the superficial epithelium. The spectroscopy and macroscopic imaging, we can see a little bit deeper, but we're still talking about primarily the first couple of millimeters of tissue. So the epithelium and then just a little bit of the supporting stroma. There will be other speakers later who will talk about methods to look deeper into tissue, look at breast tumors and things like that, where they go out into the infrared or different techniques to try to probe deeper into the tissue. In this particular case, we're primarily looking at superficial tissue regions where the precancerous changes are likely to occur. But yes, we would, if you had a deeper tumor, there would be some of these methods that wouldn't be able to see it.
Okay, thank you.
Thank you.
So in all the clinical scenarios you talked about, you had gathered multiple samples from the same patients. So for example, you had 400 samples, but 100 patients. So it seems that you see those samples from the same patient as uncorrelated data, right? So there you see them as multiple data, right? I want to know if that's both statistically correct, or there are conditions to do that generally.
You're correct that we often have multiple sites from a single patient that were measured optically, and then sometimes there are multiple biopsies from a single patient. In the analysis, we treat those as individual sites. However, when we divide the data into training and test sets, typically the data from a single patient will all go together into a certain set, into a training. We don't divide the data from an individual patient into multiple sets. I'm not sure if that was your question, though. Is that?
Yeah, I wanted to know if you generally see those data points as individual data points, or if when they're from the same patients.
Right. We do see them as individual data points, but we make sure that as I said, we make sure that we keep them together whenever it comes to dividing up the data set, if that makes sense. Other questions? Okay. Thank you. It has been a pleasure.
So let's thank Richard again.